In the meantime, I'd also like to introduce a co-chair of this workshop, Professor Barbara Rantner, and she's working in Munich. We're both vascular surgeons. I'm in Oxford, and I think probably we can start. Do you want to start, Barbara?
Yeah. Hello again, everybody. It's really remarkable that so many of you still remain to spend those 3 workshops together. And we were asked to do some daily routine case for carotid stenosis. And for this, we decided to choose this case scenario to discuss with you together how we would probably be able to manage the situation. So you detected a 90% stenosis of the left internal carotid artery in a 70-year-old female patient. With this information, what is your first thing that comes in mind? Would you ever take her into consideration for invasive treatment, or would you definitely remain in a conservative management with this 70-year-old female?
Wants to speak?
Without having any other information.
Need additional information. Speed velocity and, for example, and vulnerable plaque estimation of was it's stable or unstable plaque.
Okay.
Maybe.
So you would not think that it's anyway difficult that she is female. This doesn't bother you, does it? And the age, does it bother you? Who is bothered by the gender? No one. Oh, that's very good. I won.
You're bothered by gender?
I see a lot of those patients. I send them to the neurosurgical department, the local hospital, and they say that's no proven benefit in female in that age, so you should stick to aggressive lipid lowering and antiplatelet, and that's it.
Okay. So let's get a little bit into details. What would we do know so far about the gender differences in stroke epidemiology? And as you might know, yes, stroke is a male, predominantly male problem. So the stroke incidence is far higher among men than women, and the prevalence ratio is also much higher comparing males and females. But what we also realize is that if there ever happens a stroke in females, the case fatality is much higher in women. So you must be aware of the fact that women with an asymptomatic stenosis carry a high risk for severe impairment after having a stroke. So the data we have so far predominantly come from Allison's ACST1 trial, and there was this fear that women would not benefit from carotid endarterectomy compared with men. But finally, the 10 years results were able to show that the absolute risk reduction is more or less equal for both genders, comparing 5.5% risk reduction for males and 5.8% for females. So yes, women do benefit in the later period of follow-up. So this is what we need to take into consideration. And this leads us immediately to the question of age. So there is always the question, does the old patient benefit from an aggressive treatment? And again, you see here results from ACST1 showing that below the age of 75, both genders equally benefit. Do we have the option to? Yeah, okay. So we are comparing 0.8 to 1.8 and 0.9 compared to 2%, and the difference disappears, however, for all the ones older than 75 years. And additionally, again, the question of gender. So you see the benefit is there below the age of 75, irrespective of the gender, and it disappears for both genders over the age of 75. So as you already mentioned, it's not so easy. We cannot just take age and gender into consideration. We would need definitely more clinical information of the patient. So what would you probably be interested in?
What would you like to know?
blood flow velocity.
If we focus on clinical information, probably comorbidities,
Yeah. What do you say it like?
Plaque imaging.
Plaque imaging.
Plaque
okay.
imaging.
Anything else you'd like to know? Any other clinical information?
wonderful. Yeah, from the back, diabetes. What else might be interesting for making a decision?
Brain MRI with diffusion restriction, if there's any diffusion restriction to see if there's silent symptomatic infarcts.
Okay, so we've got silent infarcts on imaging, we've got plaque imaging. Any other clinical information?
Are there some other stents or other plaques maybe already operated on?
Other vessel disease?
Yeah.
Any reason not to do it? Any other high risk factors in her as a person? And also, what's the cardiologist up to? Are they sending her off for a bypass or something else that might change things?
Okay. Yes. So we've got some clinical information. So here's the scenario.
So fortunately, our patient is a typical vascular patient. She already suffers from a coronary artery disease, underwent bypass surgery. She's more or less well treated for a hypertension, suffers from hyperlipidemia, and has a diabetes. So which of those parameters might interest you probably most? Focusing on the carotid stenosis. Coronary artery disease?
Diabetes. Okay, so we have coronary artery disease, diabetes, and what about hyperlipidemia? You're cardiologists, how interested in treating that are you? So how many people would treat the hyperlipidemia first, for example? Can we put some hands up if you want to treat the hyperlipidemia? Yeah, I know, but it's important. Okay.
So probably you want to take over, or shall I continue?
Yeah, okay, so here then is some information on risk reduction, and you see again in brackets the number of people having a stroke each year, so as a percentage. So what you can see there is if you do endarterectomy or you don't do endarterectomy, but you have lipid-lowering treatment, you will halve the risk. So if you look at people not on it, you will halve the risk from 3.3 to 1.3%. If you look at people who are on it, you'll halve the risk from 1.8 to 0.7%. So effectively, endarterectomy halves the risk of a stroke in the future, but lipid-lowering therapy also halves the risk of a stroke. And if you look at all the other therapies there, they make no further difference, which is interesting. So that's the most important drug therapy.
And some of you also mentioned that diabetes plays a crucial role, and this is what we also learned from ACST1 very recently, that patients with a diabetes carry a significantly higher risk for a late stroke with a asymptomatic carotid stenosis. So we are comparing 1.4% compared to 2.7% for those patients with or without diabetes.
So nearly 3% of them, if they're diabetic and they have a stenosis, having a stroke each year.
But as all of you already mentioned, there are a lot of morphological details we need to consider if we decide to treat and then further decide how to treat the patient. So we have those two options, doing a open surgery or doing a stent placement. And so here is what our patient suffers from. So she has a high-grade stenosis, flow velocity, and she has an additional contralateral occlusion of the internal carotid. We already talked about a plaque ecolucency, and this is what we also learned from ACST1. Patients with ecolucent plaque carry a significantly higher risk for a late stroke onset compared to those with non-ecolucent plaques, as you can see here. We definitely need to take the anatomy of the internal carotid artery into consideration. that allows us a safe catheter passage or makes it more harmful. And here is the anatomy of the aortic arch of our 70-year-old lady. Would you like to pass this with a catheter? Probably not. Who would? Who would dare to do this?
So you really have got three options here, actually, not just two options. You have the option of going transfemorally. You have the option of going direct puncture, or I think the radial and the brachial approach are less favored, but it depends on which side you're on, what the risk is. Or you have the option of calling the surgeon. So at the moment, do we know who would call the surgeon? You want to put your hands up? Okay, who is still going to opt for medical treatment? It's a little bit less, but and who is going to suggest stenting?
Okay.
Nobody at the moment. Okay.
That's amazing, yeah. And you probably need to have some information about the cerebral conditions of the lady. So we have a look at the recent and older infarctions, and she suffered from an old infarction due to the contralateral occlusion, and actually shows no signs of silent ipsilar infarctions on the 90% ICA stenosis. The European Society of Vascular Surgery very recently published these guidelines that help you deal with patients with carotid artery stenosis. And there is this decision tree dealing with asymptomatic ones, ending in this should be treated by surgery recommendation and maybe considered for carotid artery stenting with the evidence we have so far from literature. And in this paper, there is a list of morphological factors that help to identify patients at high risk for late onset stroke with a so far clinically asymptomatic ICA stenosis. So, not very surprisingly, a silent infarction is not that harmless as it was supposed to be, which can be understood that every embolization can definitely lead to further embolization and somehow to clinical impairments. The progressing stenosis carries a high risk for getting clinically symptomatic, and there are some plaque parameters that some of them already discussed, including the intraplaque hemorrhage and the plaque lucency that help to differentiate between a stable and vulnerable plaque situation. So we also consider the other internal carotid. In our patient, she suffers from an occlusion, but we also learned that contralateral symptoms increase the risk for ipsilateral deterioration and finally symptomatic.
So we're going to look just now at the factors that make it high risk for both of the interventions. They are covered up, but now uncovered. We have covered some of these. So there are anatomical ones that you've seen in the diagram before. There are physiological ones, again going back to the older age group, and obviously relating to severe disease, pulmonary disease, heart disease, and so on. Those are the obvious ones that make it high risk for endarterectomy. If we look at the high risk for stenting, although the list is longer, we have access, lesion, and distal ICA and operator characteristics covered here. Perhaps the lesion ones we have partly discussed, and you'll appreciate as cardiologists that it's important if you're considering a stent to make sure that it's long enough to cover the lesion. But the other thing is that you don't want to kink the distal internal artery by putting in something which changes the shape. So the stent has to be the right kind of stent for the lesion. And have any of you done any carotid artery stenting? Can we see any hands? No, not yet. Well, so the stents are probably similar in some ways to coronary stents, but they come as closed cells with very small gaps, open cells with bigger gaps that are much more flexible, mixtures of these, and also membrane-covered stents, which will have tiny, tiny perforations that will perhaps protect any very soft plaque behind them. Operator characteristics, this is really obvious to you. I mean, if you haven't done it before, you need to be taught how to do it. You need to be observed, you need to be trained. And next one, here we are back again. Now, we have an option, but now you know a little bit more about it. So can we say, would you like to put hands up for who would like to stick with conservative management? Everybody's disappearing there.
That's wonderful.
Do you want to just stick to medicines for this 70-year-old lady? Yes, one person. Thank you. Okay. And who would like to send the patient to the surgeon? Oh my goodness. And who would like, with a radiological or neurointerventional colleague, who would like to consider stenting? No. Oh, well, Barbara,
the perfect case.
Put up your answer.
That's wonderful.
There we are.
Yeah,
I think
this is what we thought might be reasonable.
Yeah, we largely agree with you. Yeah. Yes. Okay, do we have any questions? Because we're just at the end of this workshop. Yes.
Presumably, in reality, you'd have an MDT type discussion with vascular radiologists or your whatever does your interventions and discuss it, wouldn't you?
I think it's absolutely right, especially if the patient hasn't had symptoms. I have to say I brought up the question of the MDT yesterday as well, because you can have a neurovascular board, which sounds very grand over here. You can have an MDT back in England where actually it just depends on the force of the personalities running it. So I think, yes, an MDT that is well balanced, I think, is very important.
Can I ask you? Thank you for interesting cases. Yeah. And for me, when I decided to perform stenting, yes, okay. Sometimes I see the patients with severe plaque, without any neurological symptoms and with slow flow.
Slow flow?
Slow flow.
Slow flow, yeah.
Slow flow, yeah. What to do in this situation? Yeah. Asymptomatic patient.
So asymptomatic with slow flow, that's a really unusual situation because they would be going to possibly occlude, and if you haven't got symptoms, that would be an unusual situation. It's much commoner with symptomatic patients that you find that the flow is very slow and the occlusion is possible. Yes, exactly. So you may have good contralateral flow. You're going to have some brain imaging. You're going to have a neurologist, you hope, and you're going to decide the evidence for intervening when the flow is tailing off is not really clear. I mean, there are quite a lot of people who can open the carotid artery without a problem, but there is also a reduced chance of stroke if you just leave it alone.
Yeah, definitely.
Okay, so we'd like to say thank you. We're about to move. The next workshop is coming to you. Thank you.
Oh yeah, this next time.
Sorry, apparently we're a bit premature. Sorry. This is actually a list of of what we think is really important for this case. So I know you can't predict life expectancy perfectly, but you need to actually work out whether you consider that long-term stroke risk is going to be important, and some of the trials will help you with that. So a lot of literature suggests that the risk is less than 1% per year, but actually that really does depend on how well the patient is treated and on these other factors that we've discussed, like have they been symptomatic in the past and have they got brain infarcts and so on. So it's not a one-size-fits-all. For some people, the risk may be quite a lot higher, but for the majority of patients, if they've never had symptoms, they've got no infarcts, they've got a stable plaque, the risk is going to be 1% or less per year with good medical treatment. So you also want a low interventional risk, and I think we discussed this. We don't like the look of the curve in the artery for stenting. And you need to know your surgeon's track records. How good are they? And you need to know that what you're going to do is going to last. So now we have some information on stents that gives us at least 5 years. We don't have long-term data really on membrane-covered stents. There are upcoming trials, and the biggest of these probably will be ACST2, comparing stenting and surgery in these patients, and CREST2, which will again be comparing medical treatment with either stenting or surgery. Do we have any other questions? Sure.
Thank you. You mentioned silent brain infarction. However, if it's a non-lacunar or lacunar, and what's your approach for leukoarrhiesis is a single finding in this case?
Sorry if I heard, you said lacunar and non-lacunar strokes? Yeah. I mean, the information, some of it is based on CT, and of course some is based more recently on MR, some is based on white, hits after things. But it seems really that if you're diabetic, you've got an increased risk. If you've got any infarction before, it shows that you've had some insult, so your risk will be somewhat higher. I can't answer for atrial fibrillation because the trials often have so few patients with that. Yeah.
Maybe it's not correct, but how many cases each year you perform in your
in asymptomatics? For me, it's a bit difficult because I switched I went
carotid
from Innsbruck.
endarterectomy, totally.
Yeah, in Innsbruck, we where I former worked, we did about 180 cases, but 2/3 being symptomatics. So, yeah, and we discussed the asymptomatics ones always interdisciplinarily with the neuroradiologists and neurologists, and tried to put them into this wonderful trial, the ACST2 trial, to get results.
Okay, and last question, thank you. What mean symptomatic patients?
What means symptomatic?
Yes, transit ischemic attack, yeah, especially with symptom of neurological insufficiency. What means symptomatic?
So I'm definitely not a neurologist, but I think neurological impairments, neurological symptoms, probably attributable to this carotid stenosis. So this is probably somebody else has a better answer for. Yes, and then we have this time, also this time information. It's supposed to be without any neurological symptoms for the past 6 months. For however reason, if the patient was ever symptomatic before 6 months, he wasn't treated. But this is another topic, probably.
Maybe you mean, vague symptoms like dizziness and things like that. No, they have to be specific to the lesion that you're looking at before you can actually really consider them symptomatic. Okay. Thank you. I think we are finished.
Thank you so much.
Thank you.